Okay, so we're going to transition into the question and answer session. So one of the questions, how do you get past the mucus buildup that prevents me from having a good urine flow? Dr. Bujons, you want to talk about that?
Okay, so as I said, the clearance and clean to clean and to clean. So if you clean the bladder and you inject more 250 millimeters of saline every day, maybe if the patient produces a lot of mucus, not all the patients produce the same. We have patients that don't produce and the other, they produce a lot. And some of them doing daily or twice a week, for example, and the other need more than once per day, maybe 2 or 3 saline to clean the bladder.
What I try to tell my patient at the beginning, they start with normal saline, and this is really expensive. And then we have, especially I learned here in the States, that we have insurance issue. So what I suggest to them is that you just get normal water from the tap, boil the water so it's clean and sterile, get it cold, and then you use that water to do the irrigation, and that works perfectly well. The most important part, at least for me, it's not just to get the 250 or 300 inside the bladder, it's to shake the bladder. So what I suggest to my patient is to do the shaking to one side, to the other, so they can have this irrigation, move the mucus, and then have the patient to take it out because it takes some time. If you notice in the 250 that is coming dirty with mucus and the catheter, it's a little stuck, do it again, because that means that you have mucus there. When the mucus is out, probably you are free for a couple of days, I would say 1 or 2. But if you notice that it's coming, just get in your regular program once a day, put it in 250, and then shake it yourself to one side, to the other, and move it out.
Yeah, so it is also important to move the catheter, because sometimes you put a catheter in the back, but sometimes we have to move a little from the left and from the right, because the mucus, because the bladder is not spheric, but the bladder enlargement, it's like they are in recovecos in Spanish, I don't know in English, but
there's some little holes and
the holes,
different,
so it's difficult to, the verticulums is difficult to extract the mucus.
When is the best age to consider bladder augmentation or Mitrophana?
Tough question. I would say when it's needed, and to have on the other side the vision that it's something that it will have some morbidity on time. So it's not cost-free, because either you need to irrigate or there's this perception, and there's some study outside that with a bladder augmentation, your risk of cancer, bladder cancer increase, and that could be between the 10 and the 15 years after the bladder augmentation. So you need to balance between continence, volume, pressure, save the kidney, and we are buying time for the future that we need to take care at some point.
Yeah. The later on, I think you want to start 20 years ago, more or less. No, we do maybe the bladder enlargement earlier than now. Now, if you have to wait until the bladder increase, for example, in teenagers, sometimes the bladder increase and they are more continent than before. And then if you can do a reconstructive surgery, for example, a bladder neck reconstruction or bladder neck closure without to do a bladder enlargement is much better. But sometimes we can, and that if you can, you have to do a bladder augmentation, but you have to follow up, as you say, PJ, because at long term it's possible to have bladder stones, other complications, or have to do a screening for bladder cancer after 10 years of the bladder and doing the bladder enlargement.
Regarding continence surgeries before versus after puberty for males, does the prostate make a difference in continence?
Yes, but the question will be, do we wait until puberty to see if the prostate will avoid us a surgery, or we just do it before and then we will see what prostate puberty will give us? And I would take that question to another topic, that if you saw in the research that we did, continence in bladder exstrophy patient was achieved around 5, if not 6 years old. Patient without bladder exstrophy, we are looking to take out the nappies around 2 or 3. So what's the difference? I know there's a bunch of surgeries in between that probably all of are scared, I don't want to. So we just push it and said, I'm good with the nappies. The same that we heard today, George, he was scared because he was living a nice life before the surgery that would allow him to go to the next step. All of us face the same. We have a healthy child that is okay, dealing with nappies. We don't want another surgery, and time passes by. And then you get older, and then we have other issues that we need to consider. So answer your question, Ted, I think that prostate will help, but I don't know if we would like to wait until puberty to have that help.
Question. I'd like to better understand whether catheterization through the mitral funnel is always necessary after augmentation, or if it's possible for some children to continue using the urethra.
Well, as I said on the study, there are a lot of varieties of how the patient can be treated. Some of patients can have micturition through the urethra. Some patients have a very troubled urethra, which has a risk of not having the possibility to get catheterization. So that's why some of them got catheterizable channel, like a security catheterizable channel if something happened to the urethra and it's not possible. Or some of them may just want to be completely dry and they decide to do bladder neck closure. So that's the aim of the catheterizable conduct when they had the bladder neck closure. So I think it depends, and as I said at the end of the presentation, it's every patient, every bladder exstrophy patient is different, and it depends on what they want, what they need, and the anatomy of them. So it's a very general question, but
so I would say that for patients struggling with incontinence, you are going to likely leak if you don't do anything about the bladder neck. So if you do a bladder neck reconstruction and you make the bladder neck where the urine comes out through the pee hole, you make it tight so that urine doesn't leak, and you do a bladder augmentation, whether or not you do it, you run the risk of having a really challenging time catheterizing through the narrow bladder neck. So I'm going to leave that decision up to the patient and your surgeon or physician, but it's very hard to reliably catheterize a bladder neck that you've tightened enough so that you're not leaking. So it's nuanced, but it's something to consider. And it is different from patients with spina bifida, who are a lot of times born with the external sphincter that can hold that urine better. So it's a little nuanced, but it's a very great question.
Yeah, and also sometimes, especially for females, it's more painful to catheterize through the urethra than it's much better or much easier to catheterize through the mitral funnel. This is the reason. When you have a female can void without to catheterize, no? Due to the bladder neck reconstruction. But I can say, Juan Carlos, it is the pain of the patient. We can say sometimes you do a bladder neck reconstruction without a mitral, but you have a risk of this so tiny, you can catheterize. So you have to talk and with the patient and with the parents.
Okay, thank you so much. We're going to transition to the next topic.